Traumatic brain injury is a leading cause of death and disability worldwide. The physical and economic burden is heavily skewed regionally. Low and middle-income countries, particularly India, shoulder a disproportionate share of global trauma-related mortality. Despite this high burden, medical literature lacks granular, hospital-level data tracking how these injuries are diagnosed and managed in these regions. To address this, we examine a specific dataset: 158 consecutive neurosurgical head injury admissions from the National Institute of Medical Sciences in Jaipur, India. Understanding how trauma care functions at this scale requires dissecting localized data rather than relying on global assumptions. The parameters for this cohort were strictly defined. Every patient admitted between April 2022 and April 2024 either had neuroimaging confirmed intracranial pathology or a minor head injury severe enough to require neurosurgical inpatient care. We will track these 158 patients through a clinical funnel, from their demographics upon arrival to their eventual discharge, to map the actual departmental workload. High-income country datasets often reflect a high proportion of diffuse brain injuries and geriatric falls. The NIMS dataset shows a different reality. Here, the operative workload is driven by young males suffering from focal, surgically significant hemorrhagic lesions. These injuries are time-sensitive. Survival depends on rapid mechanical intervention, which dictates a specific allocation of hospital resources. The clinical funnel begins with a demographic breakdown of these 158 admissions. Males comprise over 3/4 of the cohort, outnumbering females everywhere. The mean age is 34, with 60% falling into the 18 to 45 bracket. Patients with extraaxial hematomas trended older, averaging 45, while minor head injuries were the youngest, averaging 22. This demographic profile, predominantly young men in their early 30s, strongly indicates that road traffic accidents are the primary driver of these admissions. Even before treatment begins, the demographics suggest this hospital is fighting a localized epidemic of young male trauma. To classify the cohort by diagnosis, the study used a dominant lesion rule. This prevents statistical overlap when a patient has multiple traumatic findings. Under this rule, a large epidural hematoma is classified as a hematoma even if a minor skull fracture is also present, as the bleed is the primary factor in surgical decision-making. This chart breaks the 158 patients into 5 mutually exclusive primary diagnostic groups. 2 groups dominate the hospital workload: extraaxial hematomas at 37.3% and skull fractures at 29.7%. The remaining cases consist of minor head injuries, parenchymal injuries, and polytrauma cases involving the chest, abdomen, or limbs. These 5 groups branch into 16 subcategories. The extraaxial group is led by acute subdural and epidural hematomas. Skull fractures divide into depressed, linear, compound, and basal. Parenchymal injuries include contusions and hemorrhages, concluding with polytrauma combinations and minor soft tissue injuries. This diagnostic landscape is defined by focal lesions. With high volumes of acute bleeds, surgical speed becomes the primary variable for a patient's survival. The cohort split nearly in half during the intervention phase. 57% were managed conservatively, while 43% underwent neurosurgery. Conservative management included observation, anti-epileptic drugs, and hyperosmolar therapy with mannitol to reduce intracranial pressure medically. This chart shows the treatment split. All minor head injuries and nearly 80% of parenchymal injuries were managed entirely with conservative protocols. In the absence of intracranial pressure monitoring, surgical decisions relied on clinical state and mass effect visible on CT scans. The surgical burden for hematomas was high. Nearly 70% of epidural hematomas and over 53% of acute subdural hematomas required craniotomies for evacuation. In contrast, chronic and subacute subdural hematomas were managed with less invasive techniques, using burr-hole drainage. Surgery was also required for over 63% of polytrauma cases and nearly 45% of skull fractures, typically to elevate depressed bone fragments. This treatment matrix reveals a system designed for high-stakes triage, medical management for minor trauma, and aggressive mechanical intervention for expanding hemorrhagic masses. The final stage of the study measures neurological status at the point of hospital discharge. Roughly 45% of the cohort achieved full recovery, 30% had partial deficits, and 25% suffered severe deficits. These outcomes align closely with the initial severity of the injury. Patients with minor head injuries saw the best results. Over 90% left the hospital with a full recovery, and none suffered a severe deficit. Outcomes for polytrauma and acute subdural hematoma were more compromised. Polytrauma-related TBI resulted in severe deficits for 45.5% of patients. Broadly, the type of primary injury sustained is the ultimate dictator of short-term neurological recovery. The discharge data contains a statistical paradox regarding how treatment track affects outcome. Among conservatively managed patients, only 12.2% suffered severe deficits. In the surgical group, that figure rises to 41.2%. At first glance, these numbers imply that surgery leads to worse neurological outcomes. Epidemiologists refer to this as confounding by indication. The initial injury severity is the hidden variable that determines both the need for surgery and the probability of a poor outcome. In this cohort, surgeons operated on the most profoundly compromised patients. Surgery was reserved for those with the most severe focal lesions. For acute subdural hematomas, a time-sensitive craniotomy is often the only factor preventing a severe deficit from becoming a fatality. The tertiary center acts as a funnel, catching the most extreme cases of road trauma and utilizing aggressive surgery to salvage baseline function. While rapid imaging and neurosurgical access are essential, the high rate of disability despite treatment shows that the most effective intervention is systemic prevention and helmet use.